Yeah, good afternoon, everyone. And I thank Noto as well as the ISOT organizing executives to giving me this opportunity to speak in front of a topic. And I being the SOTO in charge of Government of Telangana, here it is my privilege to talk about this particular program, which we have not yet started in our state. And recently we adopted on March 26th, 2025, an Assembly Act has been done to accept and adopt the policies of 2019-94 Human Organ Transplantation Act with the rules in 2011, and also modifications which were done, amendments done during 2011 and the 14. And we have accepted this, and we are going to start the SWAP program. But to be very frank, we don't have much experience also in the SWAP transplantation program in our institute or even in our state of Telangana. But still, we would like to talk about this particular thing, about the national controversies and the consensus guidelines for the national swap transplantation program, and the challenges and the solutions for swapping in public and private sector. Predominantly, what are the differences between the two? The total solid organ transplantation, as reported by Noto in 24, is approximately 19,000, of which approximately 14,000 are the kidney transplants, of which predominantly are the living related transplantations or unrelated transplants compared to the disease donor transplantation, and which comes to around 15% only, and of which predominantly most of the donors of living related transplantation are 63%, up to 63% are women. And the total approved swap transplantation in 2011, and the first kidney exchange transplantation was done in Kerala in the year 2000, and international swap was done in the 2009. That shows that much before the adoption of this particular program by Government of India, through that the swap has been done in our country before that successfully. And there were around 582 transplant centers have been registered under Noto, of which 12.5% only are the public, and almost 87.5% are under the private sector. Then you can see the gross discrepancy between the transplantation centers in our country, and where the government ruled institutions are actually less compared to the corporate sector, where the transplantation program is going down in a hectic way. And as per this particular cartoon, you can see a map of India, where the number of participating centers in one of the studies given by Kute et al., and also the number of transplant centers which are doing actively the swap. And you can see that some of the remote corner states, as well as the major states like Goa, even Andhra Pradesh, the swap transplantation has been not done. And even as per the guidelines, even Telangana also we have not yet done, but one or two done in corporate sector. They claimed that it was actually swap, but it was done before the adoption of this particular law in our assembly. KDPD transplantation is medically approved only, as Dr. Raviraju sir was actually telling about, incompatible pair exchanges only between the two people, where the incompatible pairs are there, and because of so many other reasons. And we have an established strong cadaveric transplantation program in some of the states like Tamil Nadu, Telangana, Andhra Pradesh, and Maharashtra, Karnataka, Gujarat, etc., where the cadaver transplantation program is taking place in an extensive way. So swap probably can come in a different way. In fact, it will only expand the donor pool, so that more and more people who have been waiting for the kidney transplantation can go for transplantation easily with this particular program. And as far as this particular national snapshot is concerned, there are more than 1,800 swap transplants have taken place in India, predominantly in Gujarat. Almost 31% of the such swap transplants took place in IKDRC Ahmedabad only, and 569 out of 1839 swaps which were done. And IKDRC Ahmedabad takes the lead in such a program, and they have performed in a good number of ways, all in single center programs only. And this is basically to see that the disease donor transplantation is very less in our country, and the living related donor transplantation is predominantly the one. And probably over a period of time, it may be difficult for us to get a live related donor or even live unrelated donor also. And it is important for us to hasten up the programs of disease donor transplant as well as the swap transplants also. As we know that the women are discriminated, and they are the predominant donors in kidney transplantation, both live, but slightly the difference is almost slightly less in the disease donor transplantation, because there's a random pickup. And as far as the state-wise KPD contributions are concerned, only Gujarat, Maharashtra, Delhi, and almost less than 30% of the particular swaps done by Gujarat alone are actually done in rest of all the states from our country. So it's very important to know that rest of all the states also should make their mind to go for the swap transplantation, as advocated by the Noto, the one nation, one swap policy we are supposed to do. So what are the advantages? Probably you can get a compatible, may not be biocompatible, but blood group compatible and by all other means. And it can be done at any center in the country. People can go here and there, and the long-term outcomes are very much similar. There's no differences between the live-related or live-unrelated, or even the swap-related swap transplants. And management of policies, principles are almost the same. The only thing is that, so they need to wait for a match and they have to wait for a very, very long time, despite having a donor at home. And the coordination between various agencies, these include NOTO, ROTO, SOTO, and also the time taken to establish and upload, and these many administrative tackles also should be able to be tackled by these people properly. And this is the center performance, and it is known that the 15% of the swaps were done in public sector and 84.6% were done in private sector, and of which 36% of the transplantations done in public and 63% only were done in this corporate sector. Though it is actually how to differentiate between the two. More innovative approaches were probably given in public sector compared to the private, because private, they go with ABO incompatible very easily. They don't have to wait for a swap transplantation. And there are very few high volume centers are there in private, in government, and most of them are related or restricted only to that regional institutions like All India Institute or Nizam's Institute or even ICA DRC and some of the major Madras Medical College and all. Here, the most of the smaller and smaller size hospitals also can go ahead with the swap transplantations if it were to be the case in a corporate sector. And institutional setup is easy too, because the government only can really do that, and streamlining will be very easier. And compared to that, even in government private sector also it can go very easily. Legal permissions are easier to obtain in government. In fact, private, they have to submit so many details and other things about how to get the legal permissions into that. And kidney exchanges can be done very easily in the government public sector, and probably one or two can be done at the corporate, and cost effectiveness is also equally important. And funding, and I know that most of the centers in our country, especially public sector, are doing under the aegis of some of the other program. Especially in Andhra Pradesh, we have an Arogyasri program, and Telangana, we have an Arogyasri program. And many states have got programs. So it will be easily done for the people who have registered for such programs in private sector, government sector. In private sector, it is difficult. They have to go with insurance, or it will be very, very expensive also, because they need to go to some other place and they have to get transplanted. The cost of therapy and everything will be more in that. So easier permissions and a little bit of insurance support is there for the people in government sector. The private sector, it may be more complex and sometimes, but still the corporate hospitals are doing very good number of swap transplants easily, despite having a cost-effective nature of this. So the coordination and the logistics are very, 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 very important. That may be a major drawback as far as the government sector is concerned. If I were to send a patient of mine from a government institution to, for example, a Chennai or Mumbai or a Delhi, and who will bear the expenses of that? And it is difficult for me even to get a kidney from other states also to my side, and sending a donor recipient also to the other hospital is also very, very difficult. And also probably it will make a difference. Single center experiences by Kutte et al. Has shown there is a significant improvement with the patient donor pool, as well as the safety of the particular transplantation is also equally good when compared to that. So TOTA, what we feel is that TOTA should be able to amend some of the rules which can make the swap transplantation program across the country as a single window online registration, as well as the legal clearances should be done very easily. And there should be a centralized software-driven matching registry with prioritization, with especially the female as well as the O group and sensitized patients. I feel that even the pediatric population also should be a part of that. And the standardized inter-hospital billing and insurance directives for the swaps, and a collaboration between different states of the country and as well as the transplant centers is very, very important, so that equity and access to swap will be there properly. And adoption of AI-driven matching algorithms is very, very important, especially when you have a multi-way cycles, and it will reduce the waiting time and also enable international KPD collaborations, which are very important. And you know that the India is going to become the hub of medical thing in that, and most of the people are coming to India to get transplanted also here, and especially in Hyderabad, we could see a lot of people coming to Hyderabad to get transplanted. And also the promote capacity building and low volume centers, especially the government sector. We are supposed to improve the infrastructure as well as the human resources there. and we should have a national registry also at the same time to how to go about that, and even after that, how to follow up the patients also is equally important. Pilot programs to provide additional allocation points for the disadvantaged population, especially the females, is very much advocated in a swab transplantation program also. The government NATO advocates one nation, one swab policy across the country, and the documentation and the uniformity and accessibility and all these things should be done in a user-friendly software is required for that. Probably there may be some reforms required for the TOTA Act a little bit as far as the swab transplant is concerned in our country, and international swab should be allowed, especially with the near related donors. Thank you very much for the kind attention and the patient hearing.